So those are the basic indications. We now talk a lot about whole breast bilateral screening ultrasound, which may be of benefit for high-risk women, women with dense breasts, or women with difficult to examine breasts. And most often in our center, these are the requests that we have for whole breast bilateral ultrasound for these three subtypes. Otherwise, we do targeted ultrasound. We do ultrasound mainly of those palpable masses, of those areas that we see on a mammogram or have been referred to us from abnormal findings on other studies such as MRI. We, at this point, try not to do whole breast ultrasound because of some of the problems that have been associated with it. Just this month, a large multi-center trial preliminary report came out in the Journal of American Medical Association by Wendy Berg, which kind of gave results of a large study that she did of about 27,000 women, where she scanned, and we were part of that study, which showed that whole breast ultrasound can show more small node-negative cancers, or cancers that are early and haven't spread to regional nodes, but that can also bring out more biopsies because of more false positives. So with every cancer that you find, you may find many more other small areas that you either have to follow in 6-month follow-up or actually do a biopsy, which turns out to be benign. So adding a single screening ultrasound to mammography will yield an additional 4.2 cancers per 1,000 high-risk women, but will also substantially increase the number of false positives, was the general results of that study, which kind of means that you have to take the results of this study and fit it into your own practice. If you have a practice of women who really are very anxious, they will come for their 6-month follow-ups, they have the insurance to pay for it, they are very reliable patients and want you to biopsy as much as you can just to save them from that one that may be a cancer, then yes, you will definitely want to incorporate whole breast ultrasound. If on the other hand you have a population of patients that may not be able to come back at 6-month intervals, who don't have the insurance, who are not likely to do that, you may want to consider sticking with the targeted ultrasound for your practice. So now we'll move on to a little bit about the embryology and development of the breast. The breast is developed in embryonic life along, for both men and women, along what are called milk lines, which develop at about the 5th embryonic week. These lines have the potential to develop breast tissue along any part of them. And there are cases and people who have anomalous breast tissue which have formed anywhere from the groin all the way up into the axilla. The most common spots for anomalous breast tissue are here in the axilla, where you can have accessory breast tissue. Very common to have extra nipples. Usually what happens is this milk line regresses and just centers then on what's remaining, which will form the breasts. But sometimes you can have accessory remnants of this milk line, and you'll have an accessory nipple right underneath of the breast or on top of the breast. Some people can have accessory nipples even down into their groins, but most likely accessory nipples are right underneath of the breast. Most commonly, accessory breast tissue will form right under the armpit. And here's a statue in Soho, a section in New York, which shows a woman with multiple breasts. I don't think this ever happens, but variations of the norm do. Here's from the New Yorker magazine. This poor little turtle feels totally exposed, having his shell taken off, and that's how women feel when they come into our office for a breast ultrasound. We get them to pretty much strip down and put on this gown and put gel on them, and so we have to, before we get off into our discussion of technique, remember that this is a very sensitive exam for women, and to try to make them as comfortable as possible, try to use warm gel if you can, have a nice dry towel handy, try to expose only what needs to be exposed. Try to get them in as comfortable position as possible, because it's an unusual examination for women to have, and we want them to be as comfortable as possible. We use real-time handheld transducer from 7.5 to 13 megahertz, dynamic focus, high-resolution imaging. We lie the patient in a supine position or semi-erect. We can do the exam in any position. That's the beauty of breast ultrasound, or ultrasound in general. But in order to have a centered, stabilized, and unmoving breast, The best position is the supine position with the ipsilateral arm above the head and the shoulder elevated over either a wedge of towels or sheets, or what we use is a actual foam wedge, and that helps to center and stabilize the breast. And here's the breast tissue. If you are doing whole breast ultrasound, you do have to realize the breast tissue does extend down to the 7th rib and all the way up to the clavicle, extends as far over underneath the armpit to the what's called the mid-axillary line, and extends as far medially to the sternum. So if you are going to examine the whole breast, you have to make sure you kind of get all the way up to the clavicle, all the way down underneath of what looks like the end of the breast tissue, all the way over to the axilla, and all the way over medially to the clavicle. And then technique and how we scan in which direction: radial, anti-radial, sagittal, or transverse, and we'll talk about that in a minute. We label the images according to the mammographic clock. We label the distance, if we're imaging a mass, the distance of that mass from the nipple or areolar margin. We label the area of clinical concern, palpable mass or pain, as such. Here's an example of radial and anti-radial scanning. Here's the purpose of this, and this is very breast specific. For those of us that do ultrasound of other parts of the body, we're used to scanning in transverse and sagittal or sagittal and coronal. But with the breast, we try to follow the normal ductal anatomy of the breast, which radiates from the nipple. So we want the long axis of the transducer to be along the long axis of the ducts. Now, of course, no breast actually looks like this with the ducts radiating at regular intervals like this, but you're more likely to catch a duct in long axis when the long axis of the transducer is in parallel. So this is radial scanning, where you have the transducer oriented in this direction, and you scan radially from the nipple on out to the periphery of the breast. And then anti-radial scanning is an attempt to catch the ducts in cross-section, and again you scan from the periphery of the breast inward towards the nipple. So that's radial and anti-radial scanning. And of course you can always scan in sagittal and transverse as well, or in place of radial and anti-radial. And here's the mammographic clock. In terms of labeling on the ultrasound image, this would be the 12 o'clock position, 3 o'clock, 6 o'clock, 9 o'clock. And this is how we would like the labels to be, because labeling is very, very important, because if this has to be followed in 6 months, or if it goes to biopsy, and especially if there's other masses in that breast as well, you have to really be careful about labeling specifically where this mass is. So this is the left breast. It's at the 12 o'clock position. It's 3 centimeters from the nipple, and you're scanning in the radial plane. All of those things are very helpful, so that someone who's going to be biopsying that or following it up in 6 months can just basically lay their transducer down on that area and should be able to find it. Here's another example of that. Here's a convention where we say 3 centimeters from the nipple. Here's one where we say left breast, 4 o'clock, radial at the areolar margin. So however you choose to label, just make sure that it's clear what you're saying. Some of our scanners have these little diagrams off in the corner. That's actually not good enough. You can use your diagrams, and that will actually put a little mark of where you're scanning, but you also have to add this typed in annotation as well. And here's a portrait of a woman who we'd like to think is doing a self-breast exam, but I don't know if that's really what the artist intended to show. But when you examine your breasts, or even when we see them on mammograms and ultrasound, we don't actually see the anatomy as it is, 15 to 20 lobes, the lobule, the terminal ductal lobular unit being the functional unit of the breast, which is where most breast cancers form. We don't see those always. Now, some beautiful ultrasound technology will show us those ductal terminal ductal lobular units, which are kind of oriented horizontally, which is why we think that breast cancers grow horizontally in the breast and not, why breast cancers grow vertically in the breast and not horizontally, because the terminal ductal lobular unit is actually oriented more vertically in the breast than horizontally. That's one theory. And here you have a nice Frank Netter, famous medical illustrator, anatomy picture of the breast. And I like this one because it kind of shows a little bit like how we see the breast on breast ultrasound. Here's the skin. Underneath the skin, there's a fatty layer, the subcutaneous fatty layer. Behind that will be the glands, the ducts, the stroma, everything kind of all together. And then close to the chest wall, there'll be sometimes another fatty layer. And then here's the pectoralis muscle and the ribs. And in scanning, it's important that you see all the way through to the chest wall so that you won't miss those small masses which can grow right on the chest wall. And here's more like what breast anatomy actually looks like, this Ansel Adams photograph of a tree. Instead of that diagram that I showed that has the breast ducts radiating kind of nicely and at regular intervals, what happens is that if you just imagine this is the nipple, the ducts actually branch off in all sorts of irregular patterns. This branch is shorter than that branch, and all of the little ductules and terminal ductal lobular units are all kind of mixed up together, which accounts for the ultrasound picture of the breast. This is why we don't see ducts kind of individually and glands individually, because they're all overlapping and all kind of living in the same little space together. And how we see a breast on ultrasound depends on the amount of distribution of fat, glandular, and ductal tissue, connective tissue, and is dependent on age, hormonal status, whether someone's premenopausal, postmenopausal, pregnant, or lactating. Here's a dense breast mammographically, which corresponds to a dense breast pattern on ultrasound. Here's the skin. Here's that fatty layer underneath of the skin. And all of this is the breast tissue. Here's the chest wall muscles. And this is kind of that bright white glandular tissue that you can see with very dense glandular breasts. This is a predominantly fatty breast on mammogram, and a predominantly fatty breast pattern on ultrasound, with most of the breast being made up of these fat lobules. But most of the time breasts look like something in between, not all dense, not all fatty, but a mixture. Here's the skin, which shouldn't be any more than 2 millimeters thick. Here's the subcutaneous fatty tissue. Here's ducts as they kind of interlace in the glandular tissue, which tends to be more echogenic. So the things that are more hypoechoic are fat and ducts. The things that are more echogenic are glands. And again, we're scanning all the way back to that subcutaneous fatty tissue, all the way back to the chest wall. Here's the pectoralis muscle. Sometimes fatty lobules can look very distinct and discrete, can actually almost look like masses.